once we receive the referral, I then need to make a determination if it's safe or medically ready to start physical therapy. So how do I do that? Remember I said, when is the stability? Is it the risk benefit?
Mhm.
Look at the patient number one. Is the vital signs okay, stable enough? Look at the mean arterial pressure, look at the heart rate, look at the O2 sat, look at the cognition of the patient. If the patient is alert, able to follow, that's important. And then overall, you look at the whole picture. You have to pull all the things that you know and look, so make a determination overall, looking at the risk benefit. Is it riskier to start moving the patient, or is it beneficial to start physical therapy?
This is PT Meal Podcast, where we ingest and digest physical therapy information from physical therapists around the world with a Filipino twist. With your host, Johann de la Paz, a Filipino physical therapist who has worked in different practice settings from the Philippines and here in the US. Let's indulge and satisfy our cravings to learn and be inspired.
Welcome back to PT Meal Podcast, a buffet of play, therapies, movement, exercises, activities, and leisure, all packed in a hearty conversation of physical therapy profession and practice with a Filipino flavor. I am Johann de la Paz, your host. Welcome back to the banquet. So again, to those who are first time listeners to the podcast, or first time to watch this podcast on YouTube, this podcast is available in all streaming apps: Spotify, Apple Podcasts, Google Podcasts, Anchor, iHeartRadio, Amazon Music, and many more. You can also watch most of the full episodes and live streams on YouTube. If you want to stay updated on fresh episodes, interview snippets, research abstracts, or educational materials, follow the podcast's social media accounts in Facebook, Instagram, LinkedIn, and Twitter. Check out as well our Etsy store. Search PT Meal Shop at etsy.com for some merch. So it's one word, PT Meal Shop. So all links and content are available in the website, ptmealpodcast.com. All right. So in today's episode of our podcast, I'm thrilled to introduce our special guest, Dr. Bobby Bellarmino, a distinguished physical therapist with an impressive educational background and wealth of experience in the field. As a cardiopulmonary clinical specialist, Dr. Bellarmino brings a unique perspective to his practice, particularly in the area of ICU rehabilitation, reducing hospital readmissions in cardiovascular and pulmonary population, and improving frailty in elderly populations through rehabilitation interventions. So without further ado, let's welcome Dr. Bobby Bellarmino to our podcast and dive into an enlightening conversation about the ICU and cardiopulmonary PT specialization. Hi there, Bobby. Welcome to the podcast.
Hello. Thank you for having me, Johan. I really appreciate you for inviting me into your wonderful, exciting podcast.
Yeah, I'm glad to have you here. And at last, we're doing this. We met in person to CSM, and then we discussed about this. And I really think that there's our listeners and our colleagues would really find the value in learning more about the specialization and your work in ICU rehabilitation. But before we start, could you give us a background on how you started in physical therapy and what led you to your current role now?
Yes, let me talk about my educations. I have my entry-level Bachelor's of Physical Therapy at Virgen Milagrosa University Foundation, that's in San Carlos, Pangasinan, Philippines. And then I continue my postgraduate, finishing my Master's of Arts in Applied Physiology at Teachers College, Columbia University in New York. And then continue on to my Doctor of PT, Doctor of Physical Therapy at Mass General Hospital, Institute of Health Professions in Boston University. And then I decided, you know what, I want to study more. I want to learn more about research. So I went for my PhD in physical therapy at Texas Women's University at Houston campus. And currently I serve as the assistant professor at the Department of Physical Therapy at UT Health San Antonio in San Antonio, Texas. To answer how I started, back when after my high school, I didn't know what I wanted to do in life. One day I was sitting in our living room after graduation. My father and my mother told me, do this, do that. But there was a big push to be a nurse. And I said, you know what? I really don't want to be a nurse. Everybody in my family is a nurse. I don't want to be another nurse. I knew then nursing is not good. Nursing is a wonderful profession, but I feel like it's not for me. So one day, my aunt told me, "What are you doing?" And I said, "Nothing, maybe I should do something. Why don't you help me carry your grandmother who happened to have a stroke at that time?"
Mhm.
And she said to me, "Halika, tulungan mo ako magbuhat para dali natin sa ospital ng lola mo." So I said, "Okay, all right." Then I helped my grandmother. I was so bad because at that time I was feeling helpless. I don't know how to help her. So I carried her and took her to the rehab. And then the physical therapy helped my grandmother. And then I become interested in professions. I said to my aunt, "Can I go with you again?" And my aunt said, "Of course."
Mhm.
So then I followed and followed. During that summer, I saw my grandmother being bedridden after stroke to someone who can get up, make a few steps, and start walking. And that was the start of my fascinations of the profession. I said, "Wow, how is this happen for someone who had a stroke, bedridden, all of a sudden you can stand up and make a few steps. I want to be like this." And then after that, I said, "I want to learn about this physical therapy." But at that time, people didn't know about physical therapy. When I asked about what's physical therapy, everyone was saying, "That's masahista."
Uh-huh.
I was like, "No, it's not.
Right.
It's not." So I dig in a little bit more, interviewed the physical therapist, the one who took care of my grandmother. And at the same time, my aunt, who's an anesthesiologist, called me and said, "What have you been doing lately in your life?" And I said, "Really, I don't know. I wanted to do this, I want to do that." And she said, "Why don't you just be a physical therapist?" That was the start of my path for wanting to become a physical therapist. And now I'm here. I'm in love with the professions, and I'm so blessed to do what I love to do and get paid with it in the process.
Right. Oh, that's amazing. Usually it's either people would say they wanted to be a doctor. That's why they when they went to physical therapy, or they had a brush or experience with other physical therapists. That's why they were inspired to do the same. Amazing. So and you're as I mentioned in my intro, you're a cardiopulmonary clinical specialist. Where did that interest come from? So how did you get into cardiopulmonary physical therapy?
Yes, that's very good questions. I was in elementary and we learned about the body. I come to realize this one organ was very powerful, that has the power for life and death. When this one organ stops beating, you're done. So how is this one organ has that right? And I was one day waiting for my ride, and I was with my classmate, and he was also waiting for his ride. And I said, "Oh, what have you been doing?" "I'm waiting for my dad." And it's like he was a little bit frustrated because he was late. And I said, "Well, what's your dad do?" And he said to me, "Cardiologist." At that time, I said, "Cardiologist? What is that?" I look at it and I said, "Doctor of the heart." And at the same time, I was at that time when we were learning about the heart and lungs, and I was fascinated with the heart. And that's why I was gravitating to the organ of heart at that time. That one organ, the size of a fist of your hand. If you look, you make a fist right now and look at it, that's the size of your heart. And how is that one organ so powerful that when it stopped beating, you're done? You can have a brain dead, but you're still alive, right? But when the heart stopped, that's it. So that was the start of my curiosity in the cardiovascular pulmonary. And then throughout my career, I always interested about cardiovascular and pulmonary. But I was told early on, don't pigeonhole myself by just focusing on one area.
Right.
So after graduating, I went to different specialty, neuro, wound care, other ortho, but I always come back to my love, my passion, which is cardiovascular pulmonary. So after many years of working in different areas and kind of picked up along the way experiences working in different diagnoses, I found myself going back to my true passion, which is the heart and lungs. And then I decided, you know what, I'm going to specialize that. At the same time, the APTA at that time is really gearing up specializations. I've seen my coworkers successfully become cardiovascular and pulmonary specialists. And at the same time, I was lucky enough to work I was a traveling physical therapist at Florida at that time. And I transitioned to working to nursing home. And there was an opportunity to work in an ICU at New York, Mount Sinai Hospital. And I was lucky enough to get an interview and lucky enough to get a job. And I was really excited to work because now I got to work with the ICU, focusing on cardiovascular and pulmonary. And at the same time, many exciting things happening in the ICU, operations, surgeries, a lot of advancements. So at Mount Sinai Hospital, I find myself very invigorating, very exciting to the area of cardiovascular and pulmonary. So I parked myself there for 12 years, and through the process, pick up my cardiovascular and pulmonary clinical specialization along the way.
Oh, that's amazing. Like when I hear people like when I hear colleagues say that they did work in ICU, I was like, oh, that's amazing. Because when I was an intern and when I was working, there's little attention to physical therapists working in ICU rehabilitation, because what we're thinking as a physical therapist, that the ICU is those people who really need a lot of medical care, those who are, attaching a lot of machines and tubes, and what the heck are we gonna do in ICU as a physical therapist? So in your vast experience in ICU, what do you think is the essential role of PTs in that setting, in that
Right.
area?
That's a very good question. Before I ask that, let me tell you a bit my first experience in the ICU.
Uh-huh.
So I had the pleasure to work at St. Luke's Hospital in Quezon City.
Mm-hmm.
And that time, there were some rotations. And
Mhm.
since I like cardiopulmonary, my supervisor said, why don't you go to ICU? At that time, at St. Luke's, the ICU is cardiac care unit. So
Mhm.
I remember first patient in the ICU, I was so scared, intimidated with all lines, tubes, and drains, and all those bells and whistles. I was
Right.
just doing any passive range of motions.
Uh-huh.
And a little bit of movement, there was this noise, and I was like, ooh, I'm going to kill the patient. So
Yeah.
fast forward, I realized that the main purpose of physical therapy in the ICU is to help the patient recover from the acute illness as early as possible, as safe as possible. So it's very important for the physical therapy in the ICU to recognize the right time. Is the right time for patient to start moving now? So how do we do that? We look at the risk benefit. We need to first make sure that the patient is stable enough so that they can start the healing process. Once the patient is stable enough, we can then start the physical therapy. We start mobility. Mobility is what we provide at the ICU so they can start the healing process, recovery from the illness. So in answer to your questions, whether does the physical therapist provides in the ICU is by providing them the healing process from their illness or acute surgery.
Mhm. And how do you determine if it's the right time?
Right.
Does it come from your decision or doctor's decision?
That's yes. So there's depends on the setting, right?
Uh-huh.
I always tell my students we make our own decision because we're independent practitioner.
Okay.
So the team physicians can refer the patients to us to physical therapy if it's deemed appropriate. But we need that. We need first the referral from the sources, maybe from the physician, nurse practitioner, or PA, whatever is the protocol or the setup the ICU. Once we receive the referral, I then need to make a determination if it's safe or medically ready to start physical therapy. So how do I do that? Remember I said, when is the stability? Is it the risk benefit? Look at the patient number one. Is the vital signs okay, stable enough? Look at the mean arterial pressure, look at the heart rate, look at the O2 sat, look at the cognition of the patient. If the patient is alert, able to follow, that's important. And then overall, you look at the whole picture. You have to pull all the things that you know and look, so make a determination overall, looking at the risk benefit. Is it riskier to start moving the patient, or is it beneficial to start physical therapy? If the benefit is higher than the risk because you see there's more of the advantage, then start mobilizing the patients. Then you need to use your clinical judgment on how much you can provide mobilization at the start. And then that's why you come in with your knowledge in the ICU.
You mentioned about cognition. Are there times that you're in the ICU and you mobilize a patient who you move passively, or does it have to be the patient has to be active during interventions in the ICU?
Depends on the situations always.
Okay.
What is my goal? What is the story of this patient? Let's say, for example, a patient who just had a surgery, let's say cabbage, cardiovascular, coronary artery bypass graft. So the goal is to recover, right? The patients now revascularize their coronary arteries. So the heart needs to rehab.
Right.
So the goal is to get back on their feet. So we have to make sure that the patient is as active as possible. Their hemodynamics parameters are stable enough so that they can participate with the active movement. So patients need to be active, alert, participatory. Then let's do a different scenario. Patient is, having some delirium, agitation, and really not able to participate with physical therapy. Then I have to ask myself, what is my goal here? My goal is to diminish the negative consequences of bedridden, or should I try to come back later and see if the patients are ready for the physical therapy the following day, or maybe I can start some education, especially if they have family members that are very active and very engaging. So I have to make a decision. What is my goal? What do I want to accomplish with that? In situations like that, where patients may be, comatose, or maybe may need some patients might need a little bit more education, then I start doing that so that they can start some range of motion, something like, I always believe in human touch. I remember a patient of mine who was in comatose, and after that conversation, it becomes a learning lesson to me. And he said to me, which is quite interesting. I asked him, during the time that you were on comatose, he described to me that he was in this, what I called a vacuum of, like a swimming pool, swimming and swimming and swimming, swimming and swimming. And then other patients on comatose said to me, I was in this wild wilderness, open space. He saw was a blue sky, trees, open space. But one thing that this particular patient said to me, that he heard the voices around. He heard the voices of the nurses. He heard the voices of the family members. He said that at that moment, he didn't understand what's going on. But at that moment, it gives me this understanding that even the patient is on comatose state, they can still hear us. So at that moment, I realized the power of human touch, human connections. So I educate the patient, family members, especially the family members, to say, okay, you can do some range of motion, touch your patients, your loved ones and everything, and start engaging. Because you never know, right? You never know. So going back to your questions, whatever is the goal, whatever is the benefit of that encounter, because we are a skilled physical therapist, that encounter has to be skilled services. So I make it a point that my encounter will provide some skilled services. If there's no skilled services, then I decide to stop physical therapy, maybe hold the physical therapy, come back. So every encounter must have some skilled services that come out to that. So with patient educations, whatever. So it depends on the goal, going back to your question.
There's a big drive now, which is rightfully so, I guess, about ICU early mobilization, prevention of delirium, hospital delirium, stuff like that. How big of an impact are the physical therapists' recommendation in early mobilization and, let's say, decision making about sedation of a patient in ICU?
Right, that's a very good question. My experience led me to think that it becomes specific to facility. Depends on the culture of the facility. I will speak on my experiences at Mount Sinai Hospital and Houston Methodist Hospital. Those are large academic teaching hospitals that really embraces the early mobility. Right now, there's what we call ICU liberations, that they follow the A, B, C, D, E, F. The E is the exercise. Basically, there's team rounds every morning. The goal is to see if the patient can be less sedated, or choice of better analgesia, because of, as we know now, pain, medication become addicted. And patients in the ICU, especially the one with orally intubated, need not to be sedated. If they are, patients are participatory and they are able to not prevent any pulling of the tubes, then they can be awake. So the ICU liberation basically helps the teams to make a decision what to do best for the patients. And going back to your questions, how much contribution of physical therapy? Very good, because we then participates on, do we start mobility? Do we start early physical therapy? In that role, we are part of the process in making a decision. I'm hoping that all hospitals will follow that, or any other procedures they may have, because I do believe that not all patients in the ICU, especially when they are orally intubated, needs to be sedated. There's a situation that patient needs to be sedated for safety. I understand that, but it's not like all the time. Just because they're orally intubated, just because they are in the ICU, they need to be sedated. Tons of research says that's counterproductive. But one research also, I must remind, which is very powerful. I don't remember the exact title of that article, but they were saying that when they look back retrospective of early mobility, because there's a big push, early mobility, early mobility, early mobility. They did a retrospective study and they look at being aggressive in early mobility versus just enough. They found that those institutions who practice aggressive early mobility have more problems. Adverse effect. And when they see the benefit of that, there's no much of a significant difference at all. If my memory serves me right. I don't know. I have to go back to that article. It's been a while. But one thing that I took away from that article is that we have to, physical therapists, for me as a physical therapist in the ICU, we really have to find the right time. The right moment of physical therapy, not because you're being required to physical therapy, not because you have to follow the early mobility. We really have to make our own decision. Is it the right time for patients to start mobility? Will there be a benefit for the patient? Is there a safe adverse effect here? If there's safety precautions that we need to adhere to. Once you go through to that and making sure that this is the right time, then we need to provide that. And if it's not the right time, then we need to withdraw for that and allow the medical management takes its action so that the body can heal and appropriate timing for physical therapy can be administered.
Right. Yeah, and that's the main goal in ICU, right? It's letting the body heal, right? That's so amazing when you're talking about the ICU. There's a lot of decision making going on with just that, with a visit. It's exciting at the same time, kind of intimidating just listening to it. And there was a big spotlight put to ICU rehabilitation during COVID, right? When everyone was being sent to ICU, and the question was, are we just going to let them stay in the ICU, or are we going to let them walk with all those machines and stuff like that? Oh, that's amazing. Talking about those kinds of setting, ICU, I also hear about units called critical care units. How is critical care units different from ICU? Are they the same, or are there some differences?
Yes, thanks, Dave. Before I ask, let me allow me to say, because you mentioned about it's there's a lot of things going on decision making, right? That's why I'm going to prefix that how at Houston Methodist Hospital, I was in New York at that time teaching, and I wanted to go back to clinic. And at the same time, my life trajectory changed, and I find myself going to Houston, Texas. And at the same time, there was an offer for me to work at Houston Methodist Hospital. And I was really interested in establishing this ICU fellowship. I do believe that I've been hearing that moment, therapists, physical therapists, especially when you're newly hired, especially when you're newly graduate, are forced to go to ICU. And there's a danger for that. Although working in ICU is the safest place because you have all the help that you can and all the monitors. But again, like what you said, there's a lot of decision making. So Houston Methodist Hospital created this ICU fellowship for the purpose of training the next generation to become specialist provider of choice in the ICU, because as you said, there's a lot of things going on, decision making, not just going there and then you can, there's a lot of things to process. So ICU fellowship is what we have in Houston Methodist Hospital. Now, going back to that, ICU is a general term. Intensive care units is a general term saying that this part of the hospital is intensive. They need more care. They need more monitoring because the patient's condition is critical. The nurses needs to make sure that the patient's stability continuously monitored. So the case and the condition is, we can say, is a little bit fragile. So they need a little bit more intensive monitoring. So the word intensive care unit comes from the notions of the patient's conditions is intensive. So need that. And different hospital has different ICU, depends on the specialty area. So, for example, Houston Methodist Hospital, they have, I think, 5 or 6. Let me think. They have surgical ICU, they have coronary ICU, they're cardiothoracic ICU, and there's also a step down called IMU, Intensive Medical Unit, and there's also neuro ICU. So there's 5. So let me talk each and every one of them, those ICU. When we say cardiac care unit or CCU, that means this patient is entirely from the cardiac problem. So patients who may be on mechanical circulatory devices, meaning balloon pump, impeller devices, LVAD, left ventricular assist devices. That means the patient's heart is in a critical condition, so they need to be addressed on that because the care is more for the heart. So the nursing, the physicians, all the support system needs to center around the cardiac care. There's another one, cardiothoracic ICU. That means all the surgery that comes from the cardiac thoracic goes to that. So people who had a heart transplant, lung transplant, patients who had a video-assisted thoracic surgery, any surgery at all goes to this cardiothoracic ICU. The goal is to recover from the illness from the surgery itself. Surgical ICU, anything that doesn't belong to cardiac or cardiothoracic goes to surgical ICU. You can see liver, like liver transplant, kidney transplant, some orthopedic surgery that has some cardiopulmonary condition. For example, patient with hip and knee surgery that have some pulmonary condition like atelectasis, like collapse of the alveoli. They need a little more intensive. Now going back to neuro ICU, patients who had a stroke, patient who had a craniotomy, anything about neurological diagnosis. And then one thing now is what we call IMU. The IMU is like a step down because sometimes the patient is a little bit better. They're not necessarily critical, but still needs to be intensive care. They go to what they call step down. That means they need a little bit more care. They may need a little bit more oxygenation. They need more higher oxygenation this time. But at this stage, the patient's condition progresses in a bit so that they are just waiting to either go to regular floor or need a little bit more. Or sometimes patients are lucky enough to go home from the ICU. So those are the different kinds of units in the ICU. Depends on the care and the condition of the patient, specific, diagnosis specific, basically.
And so the term critical care unit, it's just hospital specific. Sometimes they use that, sometimes they don't.
Depends on the unit. So the ICU is a general term. The patient has a heart condition specific CCU. If they have cardiothoracic surgery, they go to cardiothoracic ICU.
Okay. All right. So in working in a ICU or as an ICU physical therapist, what are the most common cases that a PT can encounter?
Yes, bypass surgery, valve surgery. You can have patients with video-assisted thoracic surgery. Let's say, for example, they did some lobectomy. In the let's say community hospital, you can see patient pneumonia, patients who had some acute exacerbations of their COPD, who needs a little bit more intensive care, patients on mechanical ventilator. So those are the people you'll see in the ICU.
Gotcha. When we say when patients are receiving intensive care medically, is the physical therapy intervention expected to be less challenging than normal? Or you can go as intense as you can with a patient?
Depends again. I was going to say depends, right?
That's the best answer in physical therapy. It depends.
It depends. It depends. I tell my students, depends. And then my student would say, yeah, it depends. Well, it depends what's the need of the patient, right?
Right.
Nowadays, many years ago, a couple of years ago, I enjoyed working with patients for an hour, 45 to an hour, because they're just so needy. Now with their change of practice, you can only do 30 minutes to 45 minutes, typically 30 minutes really. So you have to prioritize what you can do on that time frame because you have this X amount of patients you need to see.
Right.
So in as much as I wish I could spend more than 30 minutes with my patient, the practice change. So I do prioritize what's the most important right now. And one of the things that I look at is always the breathing, because one of the things I realize is that they have a lot of gunk secretions, and sometimes those are the things that I find in my practice not being addressed to. Respiratory therapy can definitely address that. They have all the gadgets that they can do that, but there's so much they can do. Most important is how's the patient. You can teach the patient if they are the patients are awake enough. How can you make the patient independent enough to learn how to take care of their own airway clearance technique? So I spend a little more time for those patients who need that education so that they can learn how to get rid of the secretions. I've always believed that once you provided that tool to the patients, when they can be independent and able to get rid of the secretions, that's a big plus, big benefit for the patients, because then you arm the patients a tool that they can do by themselves.
Right. So you're empowering them with that simple education. The reason I asked that question earlier is I just remember I had an experience in the Philippines going to an ICU, and the only thing that we did back then, it took two of us, but the only thing that we did was passive range of motion. I was like, oh, so this is the only thing that physical therapists do in ICU, passive range of motion. And then coming over here in the US, are like, oh, there's a lot of things that physical therapists can do in the ICU. And it's like, oh, okay. But it's still scary. I mean, for me, it's scary.
Yeah. I'm glad you mentioned that, because I had experience in the Philippines when my mother sick. We took her to a hospital in where I live. I try not to mention the hospital. They claim to be world-renowned advanced hospital. They do in their own way. So my mother was in the ICU, and I talked to this physiatrist, rehab doctor, and I asked for the early physical therapy in the ICU. And I was surprised that the physiatrist at that time looked at me in the eyes and said, "Well, we don't do physical therapy in the ICU." I was stunned by that request, by that statement, and I said, "This is what I do in the United States. So what do you mean you don't do physical therapy in the ICU?" And the physiatrist said to me that nobody family members are requesting. And I said, "I'm the family member. I pay for these charges. I'm requesting for the physical therapy in the ICU." Well, get upset. So I said, "Well, sorry, I'm just going to do my own physical therapy on my mother." So yeah. So I think in the Philippines, I wish there would be more of this. And I wish that if given a chance, I would love to educate what I do in the ICU, so that the practice in physical therapy, especially in the ICU, will advance, using on my one incident and upon my own experience. It led me to believe that the practice of ICU in the Philippines needs a lot more help to advance it. And if given a chance, I would love to give that, because there's so many things that we are doing here. And I find it thinking, why not? Why is the Filipino patients, they deserve this kind of treatment as well that we're doing. We know this, what to do. We know the know-how. We have the specialty. It's a matter of political will. It's a matter of those willing to be open and for advancement. Again, it's about the patients' welfare. It's not about the physicians. At that moment, I find these physicians very close. And I didn't argue, because, we have the saying in the Philippines, it's still in the culture, I'm the doctor, I know everything. Yeah, we respect that. We really acknowledge that. But let's make a team collaborations, because if it's a team collaborations, patients win, the institutions win, everybody wins.
Right. I agree. At the same time, there's a lot of opening that door up can open up a lot of doors for physical therapists as well, not just like working in outpatient or to the inpatient outpatient systems of hospitals. PTs can work in ICUs, PTs can work in the emergency department. I mean, there's a lot of things that would open up a lot of opportunities for PTs as well.
Absolutely. And I think Filipino patient deserves that.
That's true.
We send nurses, therapists, good people to United States or other countries. They benefited us. We learn. We then can share those expertise and knowledge to their motherland, so that ultimately Filipino patients can benefit as well.
Exactly. Right. So working in an ICU, it's a team collaboration, right? What are the challenges a physical therapist can encounter in working in such setting with very acute illnesses, a high requirement to collaborate? What challenges can a PT expect in working in that setting?
Based on my experience, it's the culture. There's a culture war. It's sad that not all hospital embraces the early mobility or physical therapy aspect in the ICU. I find it that it may be just because of the support staff, or maybe the knowledge of the the people who make decisions.
Mhm.
They don't see it as beneficial.
Mhm.
So I'll put it together as a culture change.
Mhm.
The decision makers need to really embrace the paradigm shift for early mobility, early collaboration team approach, so that they can see the benefits, the advantage of team approach in the ICU and also the early mobility. Unfortunately, in as much as we are having success in other hospitals, not all have that. And I had I have to be very careful here.
I know.
I had a very interesting conversation to some of the management. I was in this setting, and I happened to talk to some of the decision makers, and I was challenging them in their mindset of why the early mobility, why is it the practice of physical therapy, occupational therapy? No, let me back up. Why is the early mobility mainframe is not being adapted? Meaning to say, patients in the or who's orally intubated can be walked by physical therapy, by respiratory therapy. We can work on that. Why is this not happening? And I find myself frustrated and at the same time pushing it because I want to create some. I felt some resistance, so I push it. So I use my position in the academia as an assistant professor, as a clinical specialist with this kind of specialty, and experience to push that forward. Because I am speaking in behalf of what I believe will be beneficial to the practice.
Right.
And I kind of challenged that. And at the end, I felt like we have an understanding, and they have some admissions that we don't practice it yet because we don't have the right people to practice it. And I said to this person, if that's the case, there's many people here that have all the specialty and know-how. You can do it. They can get training from with the use of technology right now, Zoom, webinars. It's no longer a limitation to provide the necessary training. If the institutions really are committed to that, they can invite some expert to come into their hospital and provide a day in services, and everybody can benefit it. It's also a win-win situations because it afforded the staff some continuing education. It afforded the staff some form of feeling they're getting something from the institutions. They're feeling you empower them of this knowledge. And also at the same time, you make sure the institution is providing them the best practice because we're inviting that institution. So I don't know what happened. And I do hope that I was coming from a good place. That's why I was pushing it, because I wanted to, I've learned this conversation to someone. Sometimes you need to create disruption so that the comfort can be, can be challenged. What we tend to be doing may need to be reassessed because things have changed, the practice have changed, and sometimes people who don't look at their practice maybe find themselves left behind with the advancement of practice. So I use that moment to create disruptions so that they themselves can look at what they're doing in their own practice and hopefully can make necessarily changes. I'm hoping.
All right. How does early mobility and ICU rehab impact reduction of hospital readmissions? Is there a relationship there?
Yes, there are a lot of researchers about the early mobility helping in reducing readmission, hospital stay, reducing hospital stay in the ICU, reducing the length of stay overall of the hospital, and also beneficial to the institutions because it's less hospital days.
Right.
Also, less. Many research about less hospital readmissions, which is very important right now.
Exactly.
Less mortality rate. Patients improve satisfactions. There's a lot of benefits right now. Tons of information right now available.
So it's a win for the hospital, win for the patient as well.
Absolutely, everything. That's why to say that we don't have the right people, it's a first step. But let's just not stop on that. Let's continue the conversation. Let's continue to look at ourselves. What can we do about it? Because there's so many advancements, there's so many help around it. It's just a matter of commitment, and really, you know, having that driven force.
Right. Oh, wow. There's a lot of really, things to take in with ICU rehabilitation, and there's a lot of cases as well that it would involve cardiovascular or pulmonary conditions there. And you mentioned earlier that about a fellowship and your cardiopulmonary clinical specialist. So let's talk about that for those who are interested in going into that line. How does a PT become a cardiopulmonary clinical specialist, and what are the paths?
Right, very good. Thank you for asking that question, because I wanted to share this opportunity to our listeners, those who wants to become a cardiovascular pulmonary clinical specialist. They can go to ABPTS, American Board of Physical Therapy specialty, and in that website, they can get all the information they need. But one thing is they need to have hours of direct contact hours in patients with cardiovascular disorders, and really work on that clinical skills. And then you can do your own self-audit and take the exam and see how you are, your knowledge, your skills. And if you need a little bit more help, then you can study and do your own, improvement. There's many continuing education you can do on your own.
Right.
And then when you're ready, you can sit for the cardiovascular clinical specialization exam. You do need some research, though, but the research need not to be a really hardcore research. You can be a part of the research. The purpose of that is to demonstrate that you have some form of knowledge, that you have participated in a research. A research could be a case study or anything. It need not to be a complex. You can start a small research study. And then once you complete the requirements, you can sit for that, and then you hopefully pass and you become CCS. That's the pathway for those who wants to do it on their own. That's what happened to me, because at that time there's no what called residency program. Right now, the newly graduates or younger clinician can go to this residency program, and there's tons of residency program nowadays in the United States. Depending on your areas, you can go to to ABPTS, and in that website you can look at many programs per state and see if you want to enroll in that. Basically, the way I describe residency and fellowship, right? In residency, in the hospital, here's my analogy. In the hospital, there's what we call hospitalist. Those are the internal medicine who wants to be more of the first entry for the patients. And then if they want to refer the patient to a specialist, then that's more of a fellowship, because you need more in-depth training. You need a little bit more experiences there. So the residence programs are for newly grad or a few years in experience clinicians. So you can go for that route. And then for those who want to become more specialist in the ICU, then you can do ICU fellowship. They do require a little bit more experiences. Unfortunately, with the changes of the policy, we used to have 3 ICU fellowship in the nations. Yes, unfortunately, with the change of policy, it becomes only 1. First was Johns Hopkins University and University of Chicago Medical Center and Houston Methodist Hospital. Those are the 3 institutions that have the ICU fellowship at that time. Because of the changes, I believe the Johns Hopkins and the University of Chicago's ICU fellowship are no longer active. So there's one now in existence with the Houston Methodist Hospital. Unfortunately, they're having a hard time getting some applicants, because the regulations now is that the applicants needs to be a clinical specialist first or a graduate residency program. So that policy significantly affected the pool of applicants for our ICU fellowships. Yeah, so the last time I spoke to my friend who is a coordinator of the ICU fellowship, I think they're getting 1 applicant. I don't know the specific about it, but I'm hoping that the applicant goes through, so at least they have 1 applicant, because I'm sad if they don't, because we created a really, really good program. And I'm very, very proud of it, because from the inceptions and to the development, improvement that we did, we created a program that is really good. I'm proud of it, and so much that how many of our graduates, 1, 2, 3, I think 3, became a cardiovascular and pulmonary physical therapy specialist, I think. I think, and one is sitting for cardiovascular pulmonary this year, and hopefully she will be passed. And I believe she will pass because she's bright, and we really prepared graduates of that ICU fellowship program become successful in sitting for the cardiovascular pulmonary specialty examination and became a practitioner of choice in the ICU.
I kind of get that requirement, because when you're talking about residency then fellowship, it feels like you have to be already in that industry to appreciate more to go into fellowship. Well, that's my thinking. Like you're already specializing because you're already there and you're already you're already in that waters. It's not as if you're coming from a zero experience, then you just want to go to a fellowship. It's you're already there. You already know a lot of things, and you want to enhance that.
Right. You said the key word, enhances. It will be a disservice, and the individual will feel dissatisfied with the experience of the training if they just come in with less experience, because it's going to be in depth,
right?
More focused. Educational training. So someone needs to be in this mindset, has to come with some experiences, because those experiences, those training, those education is what you're going to use as a foundation to stand on and build upon that training education that you're going to gain from this fellowship program, as opposed to going in fresh. Then it's not going to be as successful. So that's why it's important to start with the residency program. You can be a geriatric specialist. We had also an applicant who is a geriatric specialist, and he came from us from out of state, and she wants to learn more about the proper best practice in ICU. She's an experienced PT and a geriatric clinical specialist, has taught cardiopulmonary program in other PT programs. The best practice that we're learning, she now adapted the best practice.
A more structured learning.
More structured. More guided learning.
Right. I was looking at the ABPT's website. I was like, wow, the details on the data analysis project and case report. I was like, good thing they didn't have this in geriatric, because this is something else. Because you have to pass that, submit that project as well. It really shows, your dedication if you're going to go into cardiopulmonary specialization. All right. So, it was a great conversation. Thank you very much, Bobby, for coming over to the podcast and sharing your experience with us and your knowledge about ICU rehabilitation, cardiopulmonary, physical therapy. I just have my last 3 bites, my last questions for you. It's not related to the topic anymore, but this is some questions that I usually ask my guests, is that, to get to know more about you and just to close the show. So, you ready?
Yes.
All right.
Yes.
So my first bite is, what is your recipe for success?
Ooh, loaded question.
Yeah.
If I can use it for 2 words, I think. Driven and curiosity.
Care to expound?
Curiosity. You want to know more about what's going on. You don't settle for just because. You want to improve more. What do they do there differently, that successfully? What am I doing great here that I'm doing? And then be curious about many things. Learn more about this. Be driven. Just don't settle for
what is.
Yeah.
Right.
Be driven to do the best you can, because I always believe we're given this one chance in this world, and given this a wonderful opportunity to make a difference to our patients. So let's make the most of it.
All right. I love that. Be driven and be curious. All right. So my second bite is, how do you continue to sharpen your knives?
Yes. continues studying,
Mhm.
continues asking, what can I do more? What can I do differently next time?
Mhm.
And from that question, you can derive, okay, I need to learn this, I need to ask this, I need to go this continuing education program so I can sharpen my skills, and then just keep going on it.
Mhm.
Never settle, and I'm okay, I'm good enough. I have my paycheck, I have this, I'm good enough. No, we need to continue to sharpen. We need to continue to ask ourselves, what can I do better next time?
Do you have any go-to books or reading materials where you get, updates on cardiopulmonary or ICU news?
Going back again depends, right? But what
Right.
you want to learn, right?
Uh,
You want to learn about foundational knowledge. Any
mm,
books of cardiovascular is good.
uh,
For continuing education, any continuing education is good. Webinars is good.
mm,
You don't need to go to a live
mm,
presentation. You can just go with a webinar. One thing is that I must tell you also, I'm the new online education chair of the Academy of Acute Care of the APTA. Thank you, thank you, thank you. It's been so nice to be part of the APTA. So for those of you listening, I would urge you to be part of the process by being active in the APTA. However you want, you don't have to do big. Whatever you can do is a good being active, not just be a bystander. Anyway, being a member of APTA is very helpful because people have heard, oh, what's the benefit of being APTA? It's just a journal, right? Well, there's more. The APTA is the one advocating for our professions. For example, in the national level, who's advocating for the practice of physical therapy, the reimbursement of physical therapy? Many professions are trying to limit our professions or our practice. We need a body that will fight for our practice. Otherwise, we'll find ourselves in this hole, in this box that's limited. So our membership fees pays for that body to fight for our profession. So we might not see it in the direct, immediate, but in the larger scheme, it's such a powerful, because those are the one who lobby the government, who put forth some bills, who talks to the regulatory agencies, reimbursement agencies, so that our practice continues to prosper and not be limited. And also being not only that, education. So going back to become a member of the Acute Care Academy. The Academy, we always put forth free webinars. If you're working in hospitals, there's a lot of educational tools. The APTA Learning Centers has so many information there. If you are a member of APTA, you get a discount fees for that. And going to CSM is a wonderful, wonderful experiences. You get to know cool people like Johann and all the things that we met at CSM. I would not otherwise met many cool people. Many of our colleagues, Filipino colleagues, had not been to the CSM. So yeah, going there, yeah, many opportunities. It depends and how you want. Yeah,
that's true. Going to what you said about APTA, well, it's true. You wouldn't feel the impact or the movement of APTA if you're just looking at it from the outside. You have to go in. You don't have to be, so active, but you involve yourself to your specialty, to the academy, to your chapter, so you know
yes.
how things work and how we're, what we call this, how that our the organization is helping out with the profession.
Yes, thank you for reminding me. That's a good point you mentioned. You don't need to be that big. You know what? Also, to add to that, their district.
Oh,
Their
they're
district,
right.
you can just be as active in the district, and the amount of work, not really much, but you get as much of a satisfaction from being a part of that process. So just being in your community, whatever you can, as long as you be part of the process, not just a bystander.
That's true. I've been trying to be active in the California Physical Therapy Association, and I've been attending meetings. So, like, although they do a lot of things, so like kind of being overwhelmed. But I'm gonna attend a meeting this coming Wednesday in Sacramento, and I was like, oh shoot, it's really, they're doing something. I mean,
Right.
if you're not part of it, you wouldn't know how much effort and a time that they put out. Yeah, just wanted to put it out there that there's if you're just looking out from outside, it's easy to criticize. If you're not
Right.
part of something, it's easy to criticize. But if you're involve yourself there, you listen, you attend, then you can't say stuff like that, or you won't be able to say something like that.
Right.
All right. So my yeah,
District participation is very helpful too.
true. All right, my last bite is what are three ingredients that you carry with you every day that you think are essential? It can be a motto, a value, a trait, a quote, a Bible verse. So, in short, what are the three things that make up Bobby Bellarmino?
Again, loaded question. You know, I always thank God for the opportunity that given to me.
Mhm.
And as long as I am, I will try to maximize the tools, the training that God afforded me so that I can serve, the people.
Mhm.
So yeah, I always strive to do the best I can each day so that when I lay my head at night, I know I did the best I could for that particular day and given the opportunity.
Mhm. That's it. All right, good. So thanking God for the opportunity and doing the best that you can for
Yeah,
for
serve
those
the best we
opportunities.
can.
Right.
Serve
All
the best.
right. So again, thank you very much for sitting down with us, taking time to share with us your experiences in the ICU rehab and your love of cardiopulmo. If there is one thing our audience needs to take away from our conversation, yung pabaon natin sa kanila, what is that one thing that you want our audience to remember from our whole conversation?
Our patience depends on our help.
Mhm.
They are in a situations that they really need to recover
Mhm.
from their illness or acute events. Physical therapy is not something that you physical therapy services should not be taken for granted, but make sure that every encounter that we provide to our patient is the best that we can, so that our patient, when we leave the patient, we leave the patients better than we first find them, so that we know we provided the best care for our patients.
I love that. All right. Again, thank you very much, Bobby, for being here, coming over to the podcast. So I hope everyone has got something from our conversation. Repeat it, rewind it, try to get it really into your system, and catch us next week on another episode of PT Meal Podcast. Have a great day, everyone.
Thank you.